schedule. It is my great honor and pleasure to present my dear friend and colleague and brother, Professor محمد الغار. He is going to address us on successful and failed prevention of OHSS, case studies and summary of Professor الغار. Thank you.
It's my honor to give the first talk. As it was mentioned in the program, I'm going to present a few cases from the center dealing with ovarian hyperstimulation syndrome, and after that I'm going to review rapidly the management. These cases were managed under protocol designed by different doctors and colleagues from the center, keeping in mind in the background the basis of management of IVF. The first case, Heba, she is 20-year-old woman, male factor, sperm count 2 million. She was married for 2 years, and she complained of 4 years, complained of primary infertility. She was married at the age of 16, which is illegal. Long periods of amenorrhea, low FSH, high LH, and AMH was 5, and the diagnosis was male factor infertility and polycystic ovary. And she was counseled for EXI, and because she was very young and because she is PCO, she was given a very small dose of FSH, only 100 international units from day 3 of the cycle. And then we started GnRH antagonist from day 6 of stimulation, the classic protocol, fixed protocol for GnRH antagonist. E2 reached 3,800 on day 16. So as you see, stimulation continued for a very long time. Those patients, don't worry, don't increase the dose, don't panic. Keep the dose, those high-risk patients, as small as you decided, and until the late follicle reaches 17 millimeter. And the patient was ghosted for 1 day because the E2 was 3,800. Then 1 day she didn't take anything, and finally triggering of ovulation when E2 was 3,000 by only 5,000 HCG, because this also may reduce the risk of ovarian hyperstimulation. This patient retrieved 20 oocytes, 12 fertilized. Embryo transfer was done on day 4. 2 embryos were transferred. The patient became pregnant in a single viable baby, and she had 5 embryo cryopreservation. She did not develop ovarian hyperstimulation. If this patient would have received a bigger dose, or we increased the dose of FSH, and maybe if we didn't cost her for 1 day, she was very liable to develop ovarian hyperstimulation. The second case, she's again 23, young, 56 kilograms, primary infertility for 6 years, again married below the age, illegal, and again male factor, AMH was 4, and EXI was planned. This patient received the wrong protocol, and she received 2 ampoules, 150 international unit of FSH. On day 13 of starting HMG, the E2 was over 5,000. So the patient was ghosted for 3 days until the E2 went down to 1,000. During ghosting, you might not, the first day usually the E2 increases, does not drop, even increase, and then it starts to drop. But suddenly, the E2 can drop to a very low level, and then you will have very poor prognosis in this patient. This patient received again 5,000. She retrieved 15 oocytes, 9 fertilized, transferred 2 embryos on day 3, required several embryos. She developed ovarian hyperstimulation syndrome. There were 2 liters of ascites, markedly enlarged ovaries. The patient became pregnant, single viable fetus, conservative treatment of OHSS for 3 weeks without aspiration. So that is the second case. She developed moderate to severe ovarian hyperstimulation, but not the very severe forms. She did not really need any further interference. The third case is 28, and her weight is, she is obese patient. She is 97 kilograms, 4 years infertility, short period of amenorrhea. By ultrasound, she had polycystic ovary. The husband is azoospermic, and she had 3 previous trials in other centers which failed to become pregnant, and she developed severe ovarian hyperstimulation in the previous trials. This patient was put on antagonist protocol. We all know that patients who are having polycystic ovarian or disease or are liable to ovarian hyperstimulation, if they receive the GnRH antagonist protocol, you will definitely reduce the chances and the incidence of ovarian hyperstimulation. And as you see, she received also a very small dose. Few sperms was found in the testes. The gonal F continued for 11 days, then reduced to only 75 international units for 2 days. The E2 was 1800, then HCG 10,000 units were given. 23 oocytes were retrieved, 13 fertilized, embryo transfer of 2 blastocysts on day 5, 5 cryoembryos, again single viable fetus, and no ovarian hyperstimulation. This patient did not develop ovarian hyperstimulation because she was on the antagonist protocol. Historically, when she developed, she was on the wrong protocol because she received a very small dose, only 112 units, which was reduced. Again, the patient had costing afterwards, so she had all the possible precautions to reduce the incidence of ovarian hyperstimulation. Luckily, again, she became pregnant. The next case, she was married for 9 years, 29-year-old, normal hormonal profile, normal ultrasound. She was diagnosed as unexplained infertility. She was put on the long protocol, 3 ampoules, 225. On day 11, E2 was 3,300. She was costed 1 day, and E2 started to rise again, went up to 7,000 units. On day 14, E2 became 4,000, and 10,000 units of HCG was given. On day 15, 20 oocytes were retrieved. There were signs of ovarian hyperstimulation syndrome. No embryo transfer was done. Cryopreservation of all embryos, and condition of OHSS improved on conservative treatment after a week. This patient, probably she could have been treated in a better way. If you look at this patient, the first misleading point that this patient was diagnosed as unexplained infertility. She was not diagnosed as a possibly high responder patient, or there were no signs of polycystic ovary, so as to take care and to consider this in the dose and in the protocol. She did not receive also the antagonist protocol, she received the long protocol. But of course, it was discovered that she is very, very strong responder when the E2 level went to a very high level, and then she was costed, and because there were signs of ovarian hyperstimulation syndrome and 20 oocytes were retrieved, we were scared to do embryo transfer. We cryopreserved all embryos, and once there is no pregnancy, usually the condition never becomes very severe. The patient may continue to have ovarian hyperstimulation. It might be moderate to severe. She might need even aspiration, but never very severe, very, very severe forms, which happens with pregnancy and the new HCG. The next case is 37-year-old, 74 kilograms, 10 years infertility, no MH, and no signs of, was done, and no signs of polycystic ovary in her file. It was a male factor plus bilateral tubal block. This patient received 3 ampoules of HMG, the long protocol. On day 9, there were a large number of follicles, and the E2 was 17, almost 1800. 1 ampoule of antagonist was given daily, plus the 3 ampoules of HMG. As you may know, patients who are receiving the long GnRH protocol, a long time ago, it was found that if you give 1 ampoule of GnRH antagonist in this patient, you will reduce the E2 level. And usually, you may need 1, 2, maybe 3 ampoules. And we published maybe 10 years ago one of our papers on this topic, on the value of giving GnRH antagonist in patients who are already downregulated by the long GnRH protocol, and that was done in this case. On day 13, the E2 was 4,000. The dose of HMG was reduced. The patient was again coasted for 1 day, and she received 10,000 units of HCG. 30 oocytes were retrieved, 11 were fertilized, embryo transfer, 3 embryos were transferred on day 4, and we gried 7 embryos. Ovarian hyperstimulation developed with severe symptoms. Almost 5,000 milliliters of acidic fluid were aspirated. Patient received intravenous albumin. She also received prophylactic heparin because this is the highest risk complication in these patients. After 5 days, the condition continued, and so another 4,400 milliliters of acidic fluid were aspirated. Ultrasound showed 3 sacs. She had 3 embryos transferred, but with 2 viable embryos and 1 with a small non-viable fetal bone. Condition improved after 3 weeks. Well, this case, again, was a tricky case because this patient, AMH was not done. Maybe if AMH was done in this patient, would have been showed a high level of AMH, and then you would be more careful, and the dose of HMG would possibly could have been reduced. Again, there are no signs of polycystic ovary in our file. Maybe if a better ultrasound was done for this patient, maybe you have picked up that she had some form of polycystic ovary early, but because she has a male factor and bilateral tubal block, these conditions was ignored. That was thought to be the main cause of infertility, male and clear female infertility. She received 3 ampoules. If polycystic ovary was diagnosed or AMH was done for this patient, probably the dose would have been smaller. We shouldn't have given 3 ampoules, only 2 ampoules or even less in this patient. We realized early that this patient she's a very high responder, a large number of follicles, E2 is becoming high, and she received only 1 ampoule of antagonist. Maybe we could have continued the antagonist for 3 days to reduce the E2 more. And finally, we give 10,000 international units of HCG. Maybe if you have given 5,000 only, it would have been better. And right from the beginning, if we had the diagnosis of polycystic ovary or high AMH, maybe we could have started this patient on an antagonist protocol from the beginning rather than doing the long GnRH protocol. But aspiration twice all these huge volumes and replacement by albumin, finally the patient went to be safe. Again, what exaggerated the condition is that she had triplet pregnancy. So each has its own placenta, its own amount of endogenous HCG produced. This also made the condition, made it more problematic. But finally, she had twin pregnancy. The 3rd sac was not ongoing, but still, the placenta is there and HCG from this sac is there. This case, she was 31-year-old. and 74 kilograms, male factor. 3 ampoules of HMG were given. On day 7, large number of follicles. The dose were reduced to 1 ampoule only. And on day 9, E2 became 3,000 units. The patient had costing. On day 11, E2 became 10,000 picogram per millimeter. Very, very high estrogen. So the costing continues. On day 13, the E2 dropped to 1,100. 20 oocytes were retrieved, and we transferred 3 embryos and cried 5 embryos. The patient became pregnant in a single viable fetus with no HSS. The patient had premature labor, baby died, and then she had another failed trial in Port Said, and she came again after 1 year. She did another trial. She used a different protocol of which is rarely used in our center, of clomid plus 100 milligram daily plus 4 ampoules of HMG. Her weight increased to 78 kilograms. E2 on day 2, 3 embryos was transferred. Again, she developed severe ovarian hyperstimulation. Aspiration twice between 3 and 4 liters. The patient became pregnant in twins. Well, this patient, in her first trial, again, she was not diagnosed as having polycystic ovary, and probably because she had severe male factor, this patient, so that was missed. And she received 3 ampoules. She would have received much less than this. Maybe she would have taken the antagonist protocol, it would have been better. And when the E2 became 10,000 picogram per milliliter, and we continued costing, we could actually, in this case, prevent ovarian hyperstimulation. When we continued costing until the E2 level became low, this patient did not develop ovarian hyperstimulation, but because the baby died, she had a premature labor, and baby died, and she did another trial in another center, it didn't work, and came again. She took that protocol, which there is no GnRH agonist or antagonist in that protocol, only clomid and HMG. The patient developed very severe ovarian hyperstimulation syndrome, and she became pregnant in twins, and she had aspiration twice. This patient is 34-year-old, and her weight is 60 kilograms, primary infertility 3 years, polycystic ovary but regular menses, EXI with 2 ampoules of HMG. On day 10, she started to respond. Those patients don't hurry up. If she doesn't respond, don't increase the dose. Don't double the dose. Continue the small dose. Finally, they will respond reasonably. In day 12, the E2 became 2,800, and on day 14, it became 26,000. Very, very high level. Costing was done for 3 days. So we reached now day 19 in these cycles, and we did the pickup. The patient had chemical pregnancy, severe ovarian hyperstimulation, aspiration 3 times, and the condition improved after 3 weeks. So again, this patient, she is diagnosed as polycystic ovary. She took a small dose, and we continued, and we did costing for this patient, and still ovarian hyperstimulation syndrome developed. So whatever you do, some cases of OHSS will develop whatever you do. So summary of all these cases, we used small doses of FSH or HMG for the majority of these patients. Most of the patients, at least the first 5 cases, are very young patients. Many of these patients are diagnosed with polycystic ovaries. In many cases, we use the antagonist protocol, which is the right protocol for this patient at high risk. And we did not trigger ovulation in none of these cases with GnRH. We know that if you are using the antagonist protocol, the pituitary is not blocked. So you have an opportunity to give one bolus, one ampoule of GnRHA 0.25 milligram, then you will induce the natural rise of LH and you will trigger ovulation. And as you know, the natural LH have a shorter half-life time. It was not going to last long as HCG you are going to give externally. So the possibilities of having ovarian hyperstimulation with this technique is much less. And many people are using it. The problem of this technique is that it is associated with a lower pregnancy rate. So you need to do different modified systems of luteal phase support trying to improve the pregnancy rate. We used costing a lot in these patients. Costing will reduce the chances of ovarian hyperstimulation, but it will not prevent ovarian hyperstimulation. It can happen, it can occur, and it happens if you do costing. We use GnRH antagonist, not protocol. We are using in a long GnRHA protocol. We give GnRH antagonist to drop the E2. We cancel the transfer in very serious cases, and this is one of the lines of treatment. You don't have to transfer. You can cryo all embryos and transfer them later, and this is very valid, especially now after vitrification and different techniques. There is much improved pregnancy rate with cryopreserved sold embryos. Pregnancy was very high in this number, this group of patients, because most of them were very young patients with AMH. Those patients usually are having the highest pregnancy rate. Almost all those patients who became pregnant, and the majority of them had live babies. And we transferred only 2 embryos, except I think 1 or 2 cases who had 3 embryos transferred. We reduced the incidence of ovarian hyperstimulation in these high-risk patients. Expectant treatment was enough in most patients. Transvaginal aspiration fluid and anticoagulation was done in 2 of these cases who developed ovarian hyperstimulation. Just, I'm going to give you a summary of the background. How are we, theoretically, how are we going to prevent ovarian hyperstimulation? And we try to find out if we really have applied this on our cases or not. The first thing, we have to identify the patients who are high risk. History is important. Patients with a previous OHSS is very liable to develop again. And patients with polycystic ovary, these are really the most serious, most risky patients. Of course, young patients with slim patients, they are the most liable to develop ovarian hyperstimulation. And during stimulation of a patient, if it is not recognized, you will see that E2 level became very high. You know you are going into a problem. And if you find out that there are many follicles seen by ultrasound, you know you are in a problem. Naturally, any of these patients who are susceptible to ovarian hyperstimulation, the dose of FSH should be very low. Maximum, you give 2 ampoules. Usually, in young patients, slim patients, you give less, 100 maximum, or 112 maybe international units. We know that the wrong protocol is associated with a higher risk of ovarian hyperstimulation syndrome. That's why these patients, we can prefer to give the GnRH antagonist protocol, lower number of oocytes, lower E2 level, and lower risk of ovarian hyperstimulation. And as you see in a comparison between the ovarian hyperstimulation in agonist and antagonist, it is hospitalization risk, etc., is much less in antagonist protocol. Costing. Costing is you stop giving the FSH or the HMG, hoping to reduce the E2 level. And you trigger ovulation when the E2 level drops down. Cryopreservation of all embryos is another option. And 17 studies were identified when elective cryopreservation was compared with fresh transfer. No difference was found in all outcomes examined between the two groups. There is insufficient evidence to support routine use of cryopreservation. Cryopreservation will not prevent ovarian hyperstimulation, but will prevent the very severe forms of ovarian hyperstimulation when pregnancy occurs. Because already you are given the HCG to trigger ovulation, so if you cryopreserve embryos, you will not prevent ovarian hyperstimulation. But if you transfer the embryos and the patient becomes pregnant, then you will have a hell of very, very severe forms of ovarian hyperstimulation syndrome. Again, the point which I mentioned at the beginning, to trigger ovulation with GnRHa, this is a very old study which shows clearly that if you trigger ovulation by GnRHa in antagonist protocol cycles, in these patients, you will reduce the incidence of ovarian hyperstimulation very much, but you will also reduce the pregnancy rate in these patients, and you will increase the abortion rate, the miscarriage rate. So it is a good way to prevent OHSS, but it's not a very good way to improve the pregnancy rate or to enhance the pregnancy in these patients. Nowadays, those patients who are triggered by GnRH, bolus of GnRH, you can support the luteal phase by bigger dose of progesterone. You might give very small doses of HCG, like, for example, 500 or 1,000 international unit after 3 days, trying to improve the luteal phase condition of these patients. Again, metformin, most of these patients which I've mentioned today, they all take metformin. It is clear that metformin, in any cycle susceptible to ovarian hyperstimulation syndrome, will reduce the incidence of ovarian hyperstimulation. It will not improve the pregnancy rate, but will reduce the chances of ovarian hyperstimulation. So it's better to give it for all patients with PCOS during stimulation. Cabergoline was administered in 20 patients, and no severe OHSS developed. There are several studies on cabergoline used to prevent OHSS, and there is no proof that it prevents severe forms of OHSS, but it can reduce the incidence of moderate OHSS only in some cases, and actually it can be given in the patients who start to develop severe OHSS. There are several publications on that topic, and they are a bit controversial. Costing, which was done, when to start costing, we start costing when the mean diameter is 15-16 millimeter. If you start it early, you are going actually to have very poor oocytes by stopping FSH very early. So don't start it very early, but don't wait very long. What happened? The follicular growth will continue with the same rate. E2 will continue to rise, then platform, and then decline. And patients are monitored by daily E2 examination and by daily folliculometry. You give HCG when the E2 level drops below 3,000 picogram per milliliter. There are problems with costing. Sometimes, as I just mentioned, and it happens, E2 drops suddenly to a very low level, so you have to cancel the cycle. Difficulty in identification of oocytes after prolonged costing in the lab. Is costing effective in prevention of OHSS? And a large number of studies showed costing is effective in prevention of OHSS. We had a very large experience published a long time ago in human reproduction on a huge number of cycles, over 12,000 cycles, and we found that costing done for 1,200 patients, and severe OHSS occurred in 16 cases, which was 0.13% of all stimulated cycles compared to 1.8% in the previous report. So we reduced 90% of cases were eliminated. In the previous report, before 10 years earlier, in the 90s, the incidence of OHSS was 1.8. Now it became 0.13%, so it was reduced by 90%. And according to the outcome, if the costing is only up to 3 days, it will not affect the pregnancy rate. More than 3 days, you will have a lower pregnancy rate. That is the nutshell of this. And giving antagonists to prevent OHSS in patients with on the long protocol. We have a study here where we randomized patients at high risk, and we gave antagonists to one and costing to the other side, and both were very effective in prevention of OHSS. So in conclusion, we have to identify patients at risk of OHSS, and this is very important. And actually the problems which happen is that we don't identify. If you see these cases, the patients who had aspiration and severe form were not really diagnosed as polycystic ovary or very high responder, because AMH was not done or ultrasound did not diagnose that this patient is having polycystic ovary. This is the most crucial point, to know where are the risky patients to avoid, to have all precautions from the beginning. And all these patients are the patients who are at high risk of developing OHSS. During stimulation, you should be careful. You must lower the dose, change the antagonist, do the antagonist protocol, trigger ovulation with a bolus of GnRHa, or maybe if you are really in severe cases, you cryopreserve all embryos. There are some drugs which may reduce the incidence of OHSS, like metformin and cabergoline, but they are not that effective. I mean, the most important thing is the proper diagnosis from the beginning of the risky patients. Detection of high-risk patients and the use of different protocols to prevent OHSS will help to reduce the incidence. However, complete prevention so far is not possible except by not giving HCG and cancelling completely the cycle. Not cryopreservation, don't give HCG. That's the only way you can prevent HCG, and this is very hard to do from the doctor side, from the patient side, from all aspects. If you develop ovarian hyperstimulation and it's moderate, you just need follow-up of this patient, and the patient frequently come to the doctor to see that the condition is not very severe. If it is very severe, ovarian hyperstimulation syndrome, you do monitoring for vital signs, body weight, abdominal gas, urine output, and you have to correct the vascular depletion by giving intravenous albumin. You correct the electrolyte imbalance, and the most important drug you should give is anticoagulants, because by far the commonest complication of ovarian hyperstimulation syndrome finally is thromboembolism, which can occur at very serious sites in brain in different parts and can lead a permanent disability. So all these patients should take prophylactic heparin from the beginning, and you should do ultrasonographic guided aspiration of the ascitic fluid, which is very effective in improving the symptom and decreasing the complications. And we have studies long times done and published over 14, 15 years ago in this, and thank you very much.